Hello viewers, welcome to my channel. I am Puspen Dasgupta, an Indian ENT specialist, and I'm very happy to announce that some people are noticing that I am not uploading videos as per my schedule. It is always nice to be noticed. When I created a schedule for myself, it was mostly something to keep myself on track, but it's very heartening to notice that some of you have reached out to me and said that I have not been uploading MSc ENT theory question answers on Monday evenings, and mea culpa, it was a mistake, and but better late than never. So Tuesday evening today I am uploading a video on a very difficult question, in my opinion, that was asked in the theory question in MSc ENT in one of the universities in India quite recently. In fact, the question, as you can see on your screen, is discuss the principles and techniques of laryngeal reinnervation. Now, even if you don't know anything about this, what it basically says is there is a larynx which has lost its nerve supply, either entirely or partially, and that nerve supply needs to be restored. So we need to know what is the nerve supply of larynx to answer this question effectively. So you can always start the answer by saying that larynx has motor supply and sensory supply. Sensory supply above the vocal cords or above the glottis is from the internal branch of superior laryngeal nerve, and below the glottis is by the recurrent laryngeal nerve. In motor supply, all intrinsic muscles of larynx are supplied by the recurrent laryngeal nerve, except cricothyroid muscle, which is supplied by the external branch of superior laryngeal nerve. As you may know, superior laryngeal nerve and recurrent laryngeal nerve both are branches of the 10th cranial nerve, that is vagus. So we will not be mentioning these anatomical details in this answer. I will jump right into the crux of the matter. And having received the feedback from one of my students, I am going back to the older method where I have my written answer on the screen, which hopefully will act as a foundation for you to write an even better answer. For the purpose of this answer, I am using an article published in 2004 in Otolaryngology Clinics of North America, and I'll leave a link to that article in the description below. So feel free to check that article out for yourself. I know it is a 20-year-old article, but in my opinion, it is the best source available online to write an answer for this question. So if you find a better source, by all means, you can use that, but I use this source. So without further ado, let's get into the answer. As I have said before, when you are writing a 10-mark answer, you have to target writing at least 10 pages or at least 10 sides. So I've written the question here: discuss the principles and techniques of laryngeal reinnervation surgery. You start with saying that laryngeal reinnervation refers to any of a number of surgical procedures intended to restore neural connections to the larynx, which have usually been lost from some type of trauma. Now, the most common trauma resulting in damage to recurrent laryngeal nerve is surgical trauma, which can be due to thyroid surgery. And in fact, of all the severe complications following thyroid surgery, the most common complication is injury to recurrent laryngeal nerve. And it can also be a cause for various litigations, especially in developed countries. So it's very important. Suppose you are doing thyroid surgery and intraoperatively you realize that the nerve has been inadvertently sectioned. Is there something you can do? That is the whole point of this answer, and that is the whole point of the research that has gone into laryngeal reinnervation, in my humble opinion. Now, nerve functions to be restored maybe, that is, which nerves can be damaged and which nerves need to be restored. Basically the same thing. So the motor and sensory components of recurrent laryngeal nerve and the motor and sensory components of superior laryngeal nerve. The techniques that can be used to restore this nerve function can be, there are various techniques mentioned here: direct end-to-end anastomosis. This is also called neuroraphy. There can be direct implantation of nerve ending into the muscle. This is also possible. This is also called nerve implantation technique. There is nerve muscle pedicle technique, also known as NMP, and there can be muscle nerve muscle technique, which is known as MNM. So we will expand upon these techniques later in this answer. Now, in order to perform laryngeal reinnervation, we require some donor nerves. The donor nerves that are commonly used are recurrent laryngeal nerve itself, either the cut ends are anastomosed, or the contralateral recurrent laryngeal nerve can be used. Ansa cervicalis is one of the most widely used nerves. It is actually considered as the nerve of choice in many occasions. Hypoglossal nerve, or the 12th cranial nerve, is a very important nerve. It is slightly better than ansa cervicalis, but both are quite widely used. And of course, superior laryngeal nerve. Now, let's discuss direct neurography or end-to-end anastomosis technique. Now, this depends upon the availability of an adequately sized stump of recurrent laryngeal nerve. Now, this stump should have adequate diameter and it should have adequate length. Now, abductor division of recurrent laryngeal nerve is often too small in diameter to perform end-to-end anastomosis. So that is a limitation of this technique. Now, the next technique that we can talk about is the nerve muscle pedicle technique, or the NMP technique. This technique is often intended for use in laryngeal transplant surgery. Now, what is done here? Block of muscle surrounding terminal portion of a nerve is removed from donor muscle and it is sutured into target muscle. So, you find the terminal portion of nerve, take the block of muscle along with the nerve, and then remove it and then suture it back into the target muscle. So this is nerve muscle pedicle. So the pedicle contains both muscle and nerve. Now, for this trap muscle is used for abductor reinnervation of posterior cricoarytenoid muscle. As you may know, posterior cricoarytenoid is the only abductor muscle in terms of the intrinsic muscles of larynx. The limitation of this technique is that reinnervation target muscle must be within the range of length of the donor nerve muscle pedicle. Now, nerve implantation is another technique. Nerve is sutured directly into the muscle. It should be done near the site of highest concentration of motor end plates to increase the likelihood that the regenerating nerve ending will reach them. Outcomes can be measured using electromyography studies. And the final technique is the muscle nerve muscle, or M&M technique. In this technique, nerve graft is implanted into a denervated muscle on one end and into an innervated muscle on the other end. And the idea is the axons will grow from the good side onto the graft and then reach the denervated side. This method is advantageous for systems like larynx, where paired muscles normally contract at the same time. Now, if you remember, or if you have watched some of my other videos, I have also made a video on laryngeal framework surgery, especially medialization thyroplasty. So, what is the advantage of laryngeal reinnervation over medialization techniques? The medialization is a commonly done technique, whereas laryngeal reinnervation is largely an experimental technique, which is mostly restricted to animal studies, at least at the time of publication of the article in 2004. So why would we go for laryngeal innervation instead of static medialization techniques? Why? One possible answer is possibility of normal or near normal voice without placing synthetic materials inside the laryngeal framework. In medialization thyroplasty, as you may know, some synthetic materials are used. Now, laryngeal reinnervation techniques do not alter stiffness of vocal folds. Restoration of bulk to thyroarytenoid muscle is possible in laryngeal reinnervation. Improved vocal fold positioning as a result of muscular contraction of lateral cricoarytenoid, interarytenoid muscle, and posterior cricoarytenoid muscle is possible in reinnervation, not possible in medialization techniques. Also, laryngeal reinnervation is a reversible technique. You can just section the nerve that you used for reinnervation and can reverse the entire thing. Now, we will get to why you want to reverse this later in the answer. Also, laryngeal reinnervation does not preclude static methods in case of failure. So, every surgery has a possibility of failure. If laryngeal reinnervation fails, you can move on to medialization techniques. It also eliminates, you can also eliminate dysphonia in case of synkinesis by just sectioning the recurrent laryngeal nerve. We will talk about synkinesis later in the answer. Now, what are the disadvantages of laryngeal reinnervation surgery? It requires an intact donor nerve. It also requires an identifiable distal stump of recurrent laryngeal nerve. Now, reinnervation becomes effective only after a delay of several months. So that's a period of anxiety for both the patient and the doctor. Also, we cannot ignore the fact that laryngeal reinnervation procedures have an additional expense compared to medialization procedures, which are fairly affordable. Now, medialization procedures may restore the geometric symmetry to the phonating glottis, but viscoelastic symmetry can only be restored by reinnervation procedures. This is an important difference. Now, when do you perform reinnervation? The timing of reinnervation is also important. It is widely known that most iatrogenic injuries to recurrent laryngeal nerve are not detected intraoperatively. It is only detected when the patient recovers from anesthesia and has a weak and breathy voice. Now, this weak and breathy voice can also be due to endotracheal intubation. Often patients are encouraged to believe that their voice will recover with time. And what happens is most laryngologists do not advocate permanent intervention between 6 to 12 months because there is a possibility that the other recurrent laryngeal nerve can compensate, and also the recurrent laryngeal nerve that is injured may partially or totally recover. However, one also needs to remember that denervated muscles undergo atrophy. A denervated muscle will undergo atrophy. So the best results of reinnervation will only occur if the new axons reach the target muscles as soon as possible. So now we have two opposing concepts. These opposing concepts must be balanced when we are deciding when to perform, or the ideal time to perform, reinnervation procedure or any surgical procedure for that matter. Now, what are the indications of laryngeal reinnervation? Unilateral vocal fold palsy, bilateral vocal fold palsy, sensory reinnervation, as well as laryngeal transplantation. Now, before we go into laryngeal transplantation, we need to talk about laryngeal synkinesis. Laryngeal synkinesis is a factor which often determines the success of adductor reinnervation especially. Now, synkinesis is basically when the nerves are growing or the contractions are happening in a different manner in which that was intended. Now, recurrent laryngeal nerve has both adductor fibers and abductor fibers, basically adductor part and abductor part, because both abductors and adductors are supplied by recurrent laryngeal nerve. Now, suppose you want to do adductor reinnervation, you want to restore adduction, and the muscle is, and the nerve that is going is the abductor nerve. So adduction is not happening. It can be a source of major concern. Okay? Or the reverse is happening. So in that situation, what you want is, you want to prevent that from happening. You can reverse it by just sectioning the reinnervated nerve. So success of adductor reinnervation procedures in which a donor nerve is connected to the stump of the full recurrent laryngeal nerve depends in part on how many axons grow into the adductor and the abductor muscles. If the original recurrent laryngeal nerve is used for reanostomosis, both types of axons can potentially grow into both types of muscles. So cross reinnervation of adductor muscles by abductor axons or vice versa is called laryngeal synkinesis. Laryngeal synkinesis can be a limiting factor in determining the success of laryngeal reinnervation procedures. Now, functionally, laryngeal synkinesis has also been classified into 4 types. Type 1 is when the voice is satisfactory, the airway is satisfactory, and the vocal folds are poorly mobile or immobile. Type 2 is when the vocal folds are spasmodic and the voice is unsatisfactory and the airway is also unsatisfactory. Type 3 is when the vocal folds are hyperadducted and there is airway compromise. Type 4 is where the vocal folds are hyperabducted, there is poor voice, and there is possibility of aspiration. Now, the primary goal of reinnervation procedure is improvement of voice quality. It is not prevention of aspiration or airway improvement. The primary goal is always improvement of voice quality. Reinnervation has the potential to produce the best voice. That is why several surgeons prefer it to medialization techniques. Now, the factors influencing final voice after reinnervation procedure are the size of glottal gap, the severity of preoperative dysphonia, the age of the patient, the site of the lesion in the recurrent laryngeal nerve, the number of original recurrent laryngeal nerve axons that have spontaneously reinnervated the larynx, and also the degree of synkinesis caused. Now, most likely for some patients, reinnervation will be the treatment of choice, while for others, the treatment of choice should be medialization techniques. Now, let's talk about reinnervation in the context of laryngeal transplantation. As of the publication of the article that I'm using for this answer, Only one laryngeal transplantation had been performed in January 1998 in Cleveland Clinic on a 40-year-old patient who had suffered a severe crush injury to his larynx 20 years earlier. Larynx that was used for transplantation was revascularized. Both the superior laryngeal nerves and the right recurrent laryngeal nerve of transplant was sutured to those of the patient. The left recurrent laryngeal nerve could not be identified in the patient. Now, let's see what was the outcome. At 1 month, it was observed that vocal folds were in paramedian position. The vocal folds were immobile. Voice was breathy and paralytic. At 4 months, it was observed that the re-innervated right vocal fold had moved to the midline. Patient was now able to swallow normal diet, so gastrostomy tube could be removed. Supraglottis and vocal folds were found to be sensitive to touch, as cough reflex could be elicited. At 6 months, it was observed that even mysteriously, the left vocal fold had reached the midline. Even the authors could not understand why this had happened. Notable improvement was noticed in the voice. At 36 months, it was observed to the great delight of the authors that all phonatory parameters were within normal limits. Electromyography confirmed re-innervation of both thyroarytenoid and both cricothyroid muscles. Remember, we did not even find the left recurrent laryngeal nerve muscle. We didn't even find the left recurrent laryngeal nerve, so nobody really knows how that happened. Examination after 6 years, that is at the time of publication of the article, the vocal folds were still immobile in the patient. Tracheostomy was still present, which could only be removed if a chordotomy or an airway procedure could be performed, which was considered but not yet performed at the time of publication of the article. So one did note that both sensory and motor reinnervation was noted in that case, which suggests that laryngeal reinnervation is not just a possibility in animal models, but can also be successful in human beings. So of course, further research is required, and I believe this answer to this extent is good enough for an MSc ENT question. I hope you like this answer. If you have any questions, if I was not able to explain something properly, please don't hesitate to reach out in the comment section below. And if you like this format of me answering these questions, then please comment and let me know. Take care, bye-bye, and please don't forget to be awesome.